Massachusetts General Hospital. I am an orthopedic oncologist. Today I'd like to lecture you on giant cell tumor of bone. This is the histopath of a giant cell tumor of bone. We see the multinucleated giant cells and a sea of mononuclear stromal cells. The stromal cells, in fact, are the cell of origin. The giant cells, in fact, are not the histopathologic cell type. They are, in fact, an accumulation of the histopathologic cell type. The etiology is largely unknown. We know that the tumor comes from a fibroosseous stem cell. Like I said, the giant cell is not the neoplastic cell. It is certainly a tumor, a primary tumor of bone. However, it is very unclear as to where the exact cellular origin of the tumor arises. They typically occur in the second and third decades of life. We find them in the epiphyses of long bones, distal femur, proximal tibia, distal radius, proximal humerus, and sacrum, oddly enough. Campanacci has staged these tumors as 1, 2, and 3. Like all staging studies in orthopedic surgery, they rise in severity, i.e., stage 1 are not too bad, and stage 3 are terribly destructive. We see the stage 1 lesions are intracortical. They have minor symptoms typically, and sometimes even discovered incidentally. Stage 2 lesions are often intracortical, expanding the cortex. There's no soft tissue mass per se, but these are always symptomatic. Stage 3 lesions often have an extraosseous soft tissue component, very symptomatic. I think the majority of giant cell tumor bone that we see are typically stage 2 or stage 3. The lesions are typically symptomatic, as I said. In the epiphyses, there's a reasonably predictable differential diagnosis that we can conjure. Chondroblastoma, certainly in the appropriately aged patient. Intraosseous ganglion cyst, certainly in the presence of arthritis. A metastasis can always go to the epiphysis of a long bone. Clear cell sarcoma bone is a unique primary sarcoma of the epiphysis, and certainly in the sacrum, a destructive lesion midline in the sacral body, we have to think of chordoma. Oddly enough, though giant cell tumor of bone is benign, 1 to 2% of them are known to metastasize, and when they do, they often metastasize to the lungs. When I press my pathologists at the Mass General and ask them to then speak on the benign nature of the disease, they say, well, even the metastases are benign. It's certainly an oddity of nature, however, this is truly a benign disease. The surgical goals are to extirpate the tumor, eliminate the tumor burden to prevent recurrence via curettage or extended curettage. We have to restore skeletal stability and restore function. These are some diagrams of a curettage. You see on the left, there's simple curettage using large and small curettes alike. The entire window of bone is created into the lateral cortex here of the distal femur to expose the entire tumor. The lesion is thoroughly curetted out. In the diagram to the right, you see how the extended curettage goes beyond the visual or limits of a handheld curette. It's as if we're getting a wide margin then on the tumor. Intralesional curettage is the mainstay of treatment for giant cell tumor of bone. Many years ago, resection was the mainstay of treatment. However, the complications after large bone resections were such that surgeons in the mid to late 80s and certainly 90s and beyond began relying more heavily on intralesional curettage to treat this disease. And like I said, we want to see the entire lateral cortex, for example, of the femur, if that's where we're working, but in any anatomic location, the entirety of the bone needs to be exposed so that the tumor can be adequately and thoroughly curetted out. And then here you see on the right, packed with bone cement. This is a classic lytic lesion, distal femur. Campanacci stage 2 expands the cortex a bit. The differential diagnosis here in an adult would be almost always giant cell tumor bone versus, for example, a metastasis or myeloma in the right age group. Certainly this is not an adolescent, so chondroblastoma doesn't really fit. The treatment here was curettage, cement pack. It's a pathologic fracture, distal femur, giant cell tumor bone. It's a patient who was coming to see me, and in the parking lot, noticed a bag of potato chips and kicked the bag of potato chips out of her way. In kicking the bag of potato chips, her condyle broke, came to my office in excruciating pain. Our differential diagnosis was certainly giant cell tumor bone. I chose to take her to the operating room the next day. I performed open biopsy, confirming the diagnosis of giant cell tumor bone, performed a curettage, bone grafting down at the distal portion of the osteosynthesis, and cement fixation more proximally and laterally. Obviously, open reduction internal fixation was critical to restore the joint line and the mechanical zones. There are some widely accepted adjuvants that we use in giant cell tumor bone. I would say polymethylmethacrylate is the most widely used and accepted, but if you were to poll the Tumor Society, for example, you find a variety of adjuvants used by all of us. Hydrogen peroxide, phenol, alcohol, argon beam laser, liquid nitrogen is also a very effective adjuvant used ubiquitously around the world. Polymethylmethacrylate fills the tumor cavity. It has a local adjuvant effect when it gets hot. It can certainly be size dependent as far as the effect goes, but we still see about anywhere from single digit to low double digits recurrence with giant cell tumor of bone. We see recurrence typically sometime within the first 36 months. The nice thing about bone cement is because of its white contrast, we can very quickly see recurrences next to the cement, as the contrast is sometimes quite stark. It's a proximal tibial giant cell tumor bone, lateral cortex, very painful, treated with intralesional curettage, cement fixation, and internal fixation. There is some rationale to remove the anatomic unit, like a resection, to treat it almost like a cancer. This is a very large giant cell tumor bone of the distal radius. You can see the axial MRI scan, which reveals a significantly expanded distal radius with a soft tissue component. This was a patient we put on denosumab, and a large portion of the tumor turned to bone. There maintained a pathologic fracture, but you can see on the right, the soft tissue component almost went away completely. This was a tumor that I decided to resect and performed a wrist arthrodesis with an allograft. Here in a wrist arthrodesis, flexion and extension is sacrificed, but pronation is preserved grip strength. It's an excellent way of managing a problem of the distal radius to avoid recurrence. This is a large recurrent giant cell tumor bone of the distal femur. The patient had been treated with bone graft that failed woefully. This was resected and reconstructed with an endoprosthetic. There are certain bones that we can resect with impunity in the body. The distal ulna, for example, here at the left-hand side, we see the tumor that was resected, and the functional capacity of a distal ulnar resection is excellent. My indications for internal fixation are where tumor involves greater than half the width of the metastasis in the coronal sagittal plane, or where you have a pathologic fracture that requires open reduction internal fixation. My indications for endoprostheses, multiply recurrent disease, for example, where we have a significant loss of bone stock. I would consider a primary resection if we have a very large tumor, where you have primary arthrosis, for example, of the knee, or secondary arthrosis from a previously treated tumor that may be recurrent. An unreconstructible defect obviously is an indication for resection and endoprosthetic reconstruction. There are no indications for non-surgical management, especially using the drug denosumab. This is a rank ligand inhibitor that turns off osteoclasts. It doesn't treat the tumor per se, but it treats the effect the tumor has on the bone, and it's an excellent adjuvant. This is a giant cell tumor of the navicular in a 14-year-old. You can see the disease here. And after curettage and cement packing, it recurred terribly within the first 4 months. Local management in a case like this is very difficult. And this is a young lady who also had chest metastases. Again, it's a benign disease. However, with chest metastases and recurrent disease in the foot, we're stuck treatment-wise. This is a great case then for denosumab, where we saw an end to the resorptive quality of the bone and restoration of some of the bone stock and in the lungs. Other examples is a large ischial giant cell tumor bone that we put on denosumab, and after about 18 months, we see some very nice osseous consolidation here. This patient has now gone on to serial embolizations, and we're still watching him. It's a pathologic fracture, protrusion of the femoral head through an acetabular defect created by a huge giant cell tumor of bone. I placed her in an external fixator, put her on denosumab, and after about 3 months' time, we saw some nice restoration of bone stock there, and the hip ultimately became more stable. It's a case of a giant cell tumor of the anterior column of the acetabulum that we placed on denosumab. The tumor stalled, it began to turn to bone, and I converted it to a total hip replacement. That, my friends, is giant cell tumor of bone in a nutshell, and I thank you very much.